housekeeping details that we need to know. One is we want you to keep, if in case you have been given an opportunity to speak, keep your mic muted after the session of you giving a speech. And then two, we also welcome you to use the chat for general interaction. And in addition, we are also encouraging you to post your questions under Q&A section. Remember, we will be giving a CPD certificate after this webinar, probably in the next 24 hours. And therefore, we urge all that are still yet to register and make sure that your data in terms of your biodata and the information to present while registering is correct. For now, it is my pleasure to introduce our distinguished speaker, who is Mr. Bruce Onyango, a well-recognized expert in clinical laboratory management, quality systems, and JCIA standards. He has vast experience in healthcare quality and laboratory operations, and he has been very instrumental in guiding institutions towards international accreditation and sustainable quality improvement. Without further ado, let's dive into today's topic. And Mr. Bruce, welcome and take the stage.
Thank you so much, Arthur Emari. And thank you for the accolades. Yeah, so welcome. I am Bruce Onyango, as you've heard, and I hope you can all hear me.
Yes, I'm able to hear you.
Can hear me? Thank you so much.
Yes.
Yeah, so today we want to learn something about quality improvement and patient safety in the laboratory. We are trying to just minimize the topics such that we only discuss what is relevant to us in the lab. Otherwise, quality improvement and patient safety should be a hospital project, because a patient passes through all the departments if necessary. So necessarily it doesn't mean that the patient only comes to the lab and walks out. So we'll try and as much as possible. It's a wide topic, but we will strain ourselves to the lab. So quality improvement and patient safety in the laboratory, according to JCIA standards. JCIA in full means Joint Commission International Accreditation. It is a body or a group of bodies that accredits health facilities to be recognized internationally. And their main focus is in quality and patient safety. So all their standards, all their chapters, they make sure that they are construed towards ensuring that the patient gets quality service and in a very safe manner. So welcome today and Happy Heroes Day to all of us. We are all heroes in our own ways, in our homes, in our houses, in our workplaces. So feel very much proud of yourself as we celebrate today's Mashujaa Day in Kenya. So our learning objectives today will be to explain or to discuss the criticality of the quality and patient safety, outline the 6 domains of quality dimensions, to review the impact of adverse effects, or we need to know what are these adverse events, identify patient safety gaps, and see how to close those gaps, describe the role of individuals and even the organization in terms of quality and patient safety, and also occurrence variance reporting. As I've said, quality and patient safety is a very, very important area that is coming up. It didn't used to be there, but it's actually coming up very, very actively when we used to just do our services, but now it is being emphasized that we have to, all those services that we're doing, we have to do it in a quality manner and in a very safe manner to our patients or to our clients. Kenya, currently, we have a quality healthcare and patient safety bill that is in the floor of our Kenyan parliament. It had passed through the stages of public participations, and probably it's in the third or fourth reading. And very soon it will be assented into the law. And its purpose to establish stronger legal and regulatory frameworks for healthcare facilities, providers, and patients' rights. So with this, it comes with the laws and regulations, and soon our patients will have their rights. So imagine a patient knowing his or her rights, while you as a provider, you have no idea of what to do. So we need to be very much prepared to provide our services, as I've said, in a very safe manner, so that we also work within the presence of the law. So definitions: patient safety is the freedom from unnecessary harm or potential harm associated with healthcare. We used to learn about some ethical principles while in school. I remember there was 5 or 6 about, and one of them was first, do no harm. Whatever we are doing, first, do no harm. But ideally, these days, sometimes we find that the services we provide accidentally or knowingly or unknowingly, they cause some severe consequences to our patients. So yes, it's an ethical principles, first do no harm. So it is being strengthened by this patient safety or quality and patient safety. So what is quality of care? Quality of care means getting the right healthcare service at the right time and in the right way, so that we achieve the best possible outcome. It is getting the right care at the right time, in the right way, to achieve the best possible outcome. And what is quality improvement? It is a framework used to systematically improve the ways our healthcare is being delivered to our patients. And because it's a framework, means it can be measured, it can be analyzed, it can be improved, and it can be controlled. So if we go to by statistics, the impact of adverse events in healthcare by WHO, we get that around 134 million adverse events occur every year due to unsafe care in hospitals, especially in the low, medium income countries. And this contributes to around 2.6 million deaths annually. So you can imagine the number of adverse events that occur annually due to these unsafe services that we provide. 1 in 4 patients are harmed in primary and ambulatory settings, and up to 80% of this harm can be avoided. And they can be avoided by knowing how to do the right thing and also improving on our services. Medical errors cost millions of shillings in compensations to our clients, and also while trying to correct the errors and the wastages. If I can say a few examples of adverse events in the lab. When you're about to do a phlebotomy procedure to, let's say, a dialysis patient, and the patient instructs you that you can use my left hand instead of my right hand because it has got a fistula, and accidentally or unaware you don't understand or don't get whatever instruction the patient has given you, then you end up pricking the hand that has got fistula. So imagine the harm that you caused. That means that fistula may need to be used again, and an insertion of another fistula costs a lot of shillings. You can check out in your facilities right now how much is to insert a fistula. That is in terms of costs. So there's also in terms of harm. Or lab professional hurriedly sending a patient out of the room after phlebotomy procedure without checking for bleeding. So the patient ends up bleeding while he or she is outside the phlebotomy room. Or a patient calling over the phone to inquire about a procedure for OGTT or the test about OGTT or any other test that needs instructions, and you give wrong instructions. So what will be the end result? Probably you will proceed with the test when he or she comes, and obviously will get an erroneous report. And you know what that means to the patient's care. Or a patient sleep or fall asleep, a patient sleep and fall because of poor workmanship in our floors or poor design of the lab floors. So those are a few examples. Or giving wrongly post-match blood, or a lab product that was not properly stored because probably didn't do maintenance for the refrigerators. So there are several adverse events in the lab. I was just giving a few examples. Now we go to the criticality of the quality and patient safety. Why is it important to do or to emphasize or to practice quality and patient safety? So it will build integrity with your reports. It will build trust with patients and their families by providing highly reliable care. It also brings compassion. It builds relationships. It also brings about innovation, because as I've said, quality improvement is a process. All these are services that we're providing, we're able to improve them in one way or the other. So it brings about innovation. Quality dimensions of care and patient safety. Avoid harm to patients from the care that we give. We need to control risks of undesired situations and mitigate their consequences. Should be effective. The quality care we provide should be effective. The services should be based on scientific knowledge to all who could benefit and refrain from providing services to those not likely to benefit. They should be patient-centered. Patient care that is respectful and also responsive to patients' preferences, needs, and values in a dignified way, with compassion and with empathy. It should be timely, reduce waiting time and harmful delays for both who receive and those who give care. And we need to also respond to patients' needs within the defined times in our policy of services. So what is this Joint Commission International Standards? So JCIA is divided into, let me say, 3 sections. The first section that is not here is the section that gives guidelines on what is needed to be accredited. Then it also has patient-centered chapters, like the one that we're going to focus on today so much is International Patient Safety Goals, called IPSG. Then another section is for the organization, Healthcare Organization Management Safety Standards. but we'll focus so much on patient-centered standards chapter, which is international patient safety goals. So what is this IPSG? It outlines specific goals to improve patient safety. And some of the safety or which areas does this chapter focus? It focuses on the laboratory safety to ensure that we give accurate results. It also focuses on equipment safety, medical safety, facility safety, environmental safety, sanitation or prevention, infection control. And also it focuses so much on surgical safety. So it is important to, in terms of safety, it is important to identify our patients correctly. Why do we have to identify our patients? We identify so that we can give them food. Those are the kitchen people. We can administer the correct medications by the nurses and also blood products by the nurses. For us, the lab, we identify them so that we can perform phlebotomy or give instructions, lab instructions. For the surgical team, they also need to identify the correct patient before any surgical procedure. So JCIA advises that we use at least 2 identifiers, and 2 are key. That is full name of the patient and the medical records number or the hospital number. It restricts or it doesn't recommend use of bed number or patient's room to identify the patients. It is also important that for patients in the ward, we use wristbands. If the patient has the limps, you can use wristband. If on the left, on the right, depending on the policy of the hospital. If the patient doesn't have the arms, you can use the legs. If the patient doesn't have any leg for whatever reason, you can stick that wristband, a sticker on his or her scraps. In case of unknown patients, you can identify them as unknown male 1, in that order, unknown female 1, unknown male 2, and in that order progressively. It is also important, this chapter IPSG also emphasizes on effective communication. And at what point are we using communication in our daily work at the lab to give critical results, to hand over our notes to the next team that is coming after our end of our shifts. For the nurses, it can be for also in their handover notes, in prescriptions. So it's important that we write legibly. That is, we use nice handwritings that can be able to be read by the person receiving the communication. We should use abbreviations that are standardized. And whenever we have to use verbal or telephone communication, we need to write down whatever you're receiving from the person calling from the other end, and you read back that communication and confirm that actually you understood what was being communicated. This chapter has got 6 goals. 1 was correct patient identification. Number 2 was effective communication. The other one was to reduce risk of healthcare associated infections by way of waste segregation and hygiene in the lab. Another goal in this chapter is to also ensure that you identify the correct sites correct procedure and correct patient during surgery, or in this case, during phlebotomy procedure. So if we are to focus on the surgery, then we have to do the pre-surgery checks. The patient must have consented for the procedure. And also lab reports and also the imaging reports actually correlate to the surgical procedure that is about to happen. Site markings for the procedure must be done before the surgery and also in the presence of the patient and also in the presence of the surgical team. This should be done and read loudly when all the team are assembled so that they can discuss the site, they can identify the patient together, they can identify the equipments they're going to use, check whether the equipments are working. If any lab report is needed, it should be there before the procedure starts. If there's need for blood, it must be assured by the blood bank that the blood is available. Imagine a scenario where the procedure is ongoing. The doctor had already requested for some pints of blood. So the patient is already bleeding. There's no blood, or if there's blood, it was wrongly communicated to the blood bank. Instead of whole blood, they prepared platelets or any other blood products. So that is the importance of all this IPSG. Then another goal in IPSG is to reduce the risk of patient harm resulting from falls. So another goal from this IPSG that I have not included in this slide is harm from medications. So what is occurrence variance reporting or occurrence variance report? So these are internal forms used to document the details of an incident and investigations of an occurrence and the corrective action taken. What is the purpose of this OVR? To identify areas needing improvement or recognition. When do we use these forms, or when do we do the report? Is when there's any incident that is not consistent to the routine patient care, or whenever there's an injury to patient or a staff in the health facility. So what can we document in our OVR? For the lab, we can document expired blood. And for what purpose? To identify an area of improvement and for recognition. So what can we document in OVR? We can document expired blood, reagent stockout, delays in TAT. So it's also important to know the type of occurrence to report. Is it sentinel event? Is it a near miss event? Is it an adverse event? Or is it a no harm event incident? So what is this sentinel event? These are unexpected occurrence involving death or serious physical or psychological injury, not related to the natural cause of the patient's underlying condition, e.g. homicide or death that is not related to the natural cause or natural disease that the patient had. It may be due to suicide in the ward or suicide in the hospital. Those are just examples, or an infant abduction by wrong patients. So those are what we call sentinel events. They may cause death or a serious psychological injury. Near-miss event is any incident directly associated with care provided within the health facility that would have resulted in an accident, injury, property damage, or an illness, but did not happen either by chance or through timely intervention. Its recurrence carries a significant chance of serious adverse outcome. Adverse effect, any change or side effect that occurs while the patient is receiving treatment, e.g. a hematoma after phlebotomy procedure. No harm incident is an incident that it is not a normal occurrence, or it's not a normal practice, but it happened and it did not cause any harm to our patients. A simple example is administering an ear drop to a wrong ear. So it may not cause a harm, but it is an incident to report. What are some of the policies that are guiding occurrence variance report? So this occurrence should be reported immediately. It should not be used to criticize or to blame the staff involved. Corrective actions taken to minimize risk of injury and adverse effects, and they have to be documented. The report should be open and transparent, because it will involve a team and also the staff involved and probably the witness. And they're also system-based, because there are systems designed to prevent, to analyze, and to document this OVR. It is also important to emphasize that who should report this OVR. The staff involved can report the OVR. A witness can report the OVR. Or any other person who saw or who was involved or who was reported to. For example, if a staff complains, the person who is going to receive the complaint can also report the OVR. However, it is important to note that in as much as these OVR are not intended to criticize or to blame the staff, but there are some reckless errors that should be punished. And those that are unintentional are reported so that to prevent recurring. So after reporting the incident, what do? We need to do a root cause analysis for it. So the purpose of the root cause analysis is to understand how and why an event occurred, and to prevent the same or similar event from recurring in the future by analyzing the cause and the causes, then mitigating. Just as we've learned, what are the adverse effects to report? So same as when do we do a root cause analysis? It's all the same. Whenever there's a confirmed transfusion reaction, whenever there's an adverse event related to patient misidentification, whenever there's an adverse event during or after phlebotomy procedures, whenever there are serious drug reactions, whenever there's a significant medical error by the nurses or the doctors, the clinical team, or for any other reason that has got an adverse effect to the patient, we do a root cause analysis. So how do we do the root cause analysis? We define the problem, we collect data, we determine the possible causal effects, we identify the causes, then we can recommend a solution and implement. There are tools used to do root cause analysis. We've learned them in our previous webinars. You can employ the 5 whys. You can employ the Pareto principle. You can employ the fishbone analysis that focuses on the 6 M's. I may not go into details, but those are tools to to do the root cause analysis. So once you've done the root cause analysis and you've implemented the reason, or you've implemented whatever mitigation you've taken, it is important that we do quality improvement so that we can learn or we can improve our processes to avoid a recurrence of the adverse effects. So for quality improvement methodology, we can use one way of doing it is by doing a focus PDCA. Some people call it focus PDSA methodology, where F stands for find the problem or the process to improve. You may identify that you want to improve your turnaround time in the lab or the way you report your critical values. You organize your team. You discuss with them the problem. The people that you can learn alone. You can do your meetings and identify the problem. You clarify with the team the process or how it works. You come up with tools, targets. If, for example, you want to, we can pick on critical value reporting. You will come up with tools and how to collect data on critical value reporting. Probably you can say you can say that if your critical value reporting was taking too long, you can come up with a target of, let's say, you want to report your critical values within 15 minutes. And actually, JCIA recommends between 15 to 20 minutes of reporting our critical values. So what will you assemble? You assemble which tools will you be using? Will you be using your lab registers? What tool will you be using to analyze your data? Then it's also important to understand the root cause of the problem. What is delaying critical value reporting? Is it because you have manual processes, or is it because you don't have an effective communication channel? Then you select an improvement strategy. How do you want to, once you understand the root cause problems, you also select a strategy on how to improve the problem or how to mitigate the problem. For PDSA or PDCA, it involves planning the activity aimed at improving, carrying it out, or then you check and study the results. If the results are satisfactory, you can adopt the change. If not, you can abandon it and run through the cycle again by finding the problem, organizing your team, clarifying the process, understanding the root cause, and selecting an improvement strategy. So another way of doing quality improvement project is by use of Six Sigma roadmap, more or less the same as Focus PDSA, where you define the task or goal. Same as the other one, you can decide that you want to improve your critical value reporting. You measure the current standards, whatever you're currently using. You collect information and conduct analysis. You improve or shortlist some of the solutions and use the best fit of all. Then you control or you implement the project and monitor. The other way is also to use failure mode and effect analysis. You detect the failure mode, you identify the severe ones, probability of occurrence, likelihood of detection. Then you do your calculation. It's called you identify the risk priority number using that formula above. So quality improvement tools. Which tools will you be using to improve your quality? You can be brainstorming by the team and gather ideas spontaneously together. You can do multi-voting. You can identify a list of options to improve or strategies to improve. Then you vote according to the priority of the list. Your data collection tools, flowcharts, fishbone diagram. Just as we said, for example, if you want to improve on critical quality reporting, that will be your activity or that will be your project. You can say that you want to report all your critical laboratory results within 15 to 20 minutes. And that is according to the JCIA standards that you repeat. It's important to report all your critical values within 15 to 20 minutes. So you define your critical values. If it is RBS, you can define that anything below 2 millimoles per liter or anything above 16 or 18, depending on your lab policy, you mark it as a critical value. If it's about all your blood cultures that turn positive are all critical values, you define each one of them. You define the data to collect. For example, you can say at what time was it confirmed as a critical value. If it is RBS, after doing it for the first time, then according to your lab policy, you can say a confirmatory test doing it for the second time. If it gave you the second reading or the confirmatory time, the confirmatory value at, let's say, at 12:30 p.m. So that will be the time confirmed. Then the time reported, at what time did you report this value to the appropriate person who you should report the critical values. At what time did you report it? It's at 12:40. So that means your data that you'll be picking is 12:40 minus 12:30, that is 10 minutes. So what is your target? Your target may be 100% of all the critical values should be reported. Frequency of your reporting, you can decide it's weekly or monthly. You can set the period to do the improvement. You want to do the improvement in 3 months or in 6 months. So you can set the period to do the improvement. Then how will you now calculate to achieve 100%? Is you will identify or you will count the number of timely reported critical values. Those that fall within the target you had set, if it's within 20 minutes or within 15 minutes, you count that number, divide by the total number of critical values during that period. So you take the total number of timely reported critical values divided by the total number of critical values in that period times 100. So if your critical values were 20 in that month, and those that were timely reported were 15, so it's 15 divided by 20 times 100. That will give you 75%. So it means you shall have fallen off your target. But because of our topic, which is patient safety and quality improvement, it is important that this activity or this project, it should be 100% to ensure safety of the patient and to also achieve what is called quality care. That is providing services in the right way at the right time. So as you will be doing the project, you can, for this particular critical reporting of critical results, there should be no inclusion of exclusion criteria. Who is championing these projects? It may be your QA, or you assign a person to oversee the project. Your sample size should be all the critical results coming from the lab. That should be a sample size, so it should be 100%. What method will you be using to collect your data? You will just be using your lab registers. If they're manual, you will be checking your hard copy lab registers. If you are using an information system, you can access all this information in LIS. Then you report the data. So after the end of this project or this quality improvement project, you can decide to either adopt or discard. If you see that it's not achieving any safety or any quality to the patient, you can discard it or you can modify. But for this one that we identify, which is reporting critical laboratory results, you just need to adopt it fully. Thank you so much. We can ask any question. You let us make it as interactive as possible. Over to you, Arthur.
Thank you so much, Bruce, for that quite informative presentation. And now we want to look at the Q&A section. We want to look at the Q&A section and see the type of. So we urge our participants to at least post their questions under Q&A. And we're looking at our first question from Robert Cheroyot. And it goes, Robert Cheroyot is requesting for slides. Robert, we urge you to engage with our YouTube channel. Please visit our YouTube channel and you can get the slides from there. You'll be able to learn a lot, or you can check in our learning hub, and you'll also be able to learn much from those areas. We're looking at other questions that are coming in. We have a question. Okay, yeah, thank you. Thank you so much, Roslyn Nyamwaro. Josephine Malala from Kakamega. Thank you so much. We have Austin Odundo from Kisumu. We have Fantas from JCIA Hospital. We have Kennedy Peter from Matunda, Kisumu. We have Lamek from Brimaxa Hospital, that is in Busia branch. Yes, so we have Issa from Marsabit. Yeah, we also have Naomi from Kerugoya. We have quite a number of attendees making comments here. So it's much about Mashujaa Day. That is much that we're getting. So we are hoping that we are able to share our questions under Q&A, and we are waiting for the questions. So far, we don't have any question that has been put so that we can maybe. Thank you. We have one question from Lillian Ouma, and the question is, what's the best design for laboratory floors? Back to you, Bruce. Bruce, are you able to hear me? Bruce, are you able to hear me?
Hello, Arthur. Hello?
Yes, are you able to hear me?
Oh, yes. I've had the question. It's about the best way to do floors. It should be one that is focusing on safety, hygiene, and durability. It should be non-slippery. So as I've said, it focuses on the safety of the people that will be using the floor. Hygiene, is it easy to wash, and also durability for the floor. So it should be not slippery or slip resistant. It should also not be able to absorb the waters that will be used to mop. And it also should be very easy to clean. So it's advisable that you use our tiles, non-absorbent ones, and also not slippery.
Thank
Thank
you.
you so much.
Let me check on our question 2 from Susan 10, and it goes. Kindly clarify better the difference between sentinel and near miss on types of OBR. Back to you, Bruce.
Thank you so much. So sentinel events are those that are they don't necessarily come from the services that you are providing, but their occurrence may cause death or a serious physical injury or a psychological injury to the patient. So as I said, an example is an infant abduction by the wrong patients, or a suicide in the hospital, or even a homicide. We've seen such cases even in our country. And a near miss is any incident that is directly associated with the care that you are providing, but it didn't happen maybe by chance, or it was by a timely intervention. So that is the difference, Susan.
Thank you. Let's look at our next question from Lamek on Tweka, and it goes, how can we ensure that stool and urine collected from adults is fit for analysis? Back to you, Bruce.
Come up again.
Yes, let me come up again. The question is from Lamek on Twitter, and it goes, how can we ensure that stool and urine collected from adults is fit for analysis?
Thank you so much, Arthur, and to Lamek for the question. There is a criteria for acceptance of samples that we receive in the lab. So stool and urine collected, first of all, you identify the stool and the urine with the patient. Is the sample labeled same as the request form provided? And also, if you can connect the two to the patient. is the sample sufficient? What was the collection time? So depending on all these factors, you can either accept or reject, also depending with the lab policy, wherever you work. Thank you.
Yes, Bruce. Let's look at our next question from. There were two questions. Let me check from this other area and see if we have any additional questions. We have got Morris Ndova from one university. He is excited and he is indeed commenting in this great platform and appreciating the exciting presentation that you're having. We don't have any other question in our question area, and our chat box is also we have another question that has just come in from Peter Owako, and it goes, what are the features of a well-designed incident/accident occurrence register? Back to you, bro.
Thank you so much. It should contain the incident itself, the person reporting, the time, date. You also identify also whether is it a sentinel, is it a near miss, is it an adverse effect, is it a no harm incident? Then you also indicate an action that was taken when you got the report or when the incident occurred. That is the action that was taken. And also the corrective action taken after the report.
Thank you. I have a question from, I have another question from Lilian Ouma, and it goes, there are relatives of patients who bring samples which are not labeled, but they insist that the samples have been drawn by doctors. So the question is, how do we handle this?
Ideally, you need to reject the samples, especially if they're blood, urine samples. But there are those samples that are in quotes difficult to collect. For example, biopsy samples, or let's say CSF, the pleural fluids. So you can insist to the relatives or to the doctor to make a signature that actually the unlabeled samples are for the patients that they claim they are for. Over to you, Arthur.
Yeah, thank you. Oh, yes. Good. We are done with the questions.
But let me add, but it's also important that you as the lab professional, even after receiving the signature from the doctor or from the relatives, you also document it as an adverse effect. Thank you, Arthur.
Thank you. Yes, another question has just come in from Daniel Nyachiro, and it goes, what should you do when a full hemogram control fails? But when run within runs, it's normal. I don't know, Mr. Bruce, I don't know if you've heard that question well, or I should repeat.
You can repeat.
Yeah, a question from Daniel Nyachiro, and it goes, what should you do when a full hemogram control fails? But when run within run, it's normal. Back to you, Bruce.
I don't know what Nachiro mean by run within run, but whenever there's a failure in our QCs, we need to do a kappa, that is a corrective action, preventive action, so that we can know where the problem might have occurred. Is it with the material, the QC material itself? Is it with the equipment? Is it with the lab professional doing it? Is it with the method? So ideally, you do the 6 M's in fishbone. You also ask yourself the 5 whys. Then you will come up with a conclusive reason to why they failed, and by so doing, you shall have come with a preventive action so that it doesn't recur. Thank you.
Thank you so much. Yes, let's look at another question. From Martin Kamaki, and it goes, how can you handle stubborn management? How can you handle a stubborn management? Back to you, Bruce.
Martin should be specific on they're stubborn on what areas, so that we can also be able to handle his issue.
I think he's referring to management that is a bit rigid, probably, on how it's running the affairs of an institution. So, like as a worker, I mean, how do you handle, as a medical lab professional, how do you handle such kind of bosses?
It will be so unfortunate if they are stubborn on areas that are touching on patients, because we've learned that our services should be patient-centered, and we should be able to provide quality care and in a very safe way. So it will be so unfortunate that if they are stubborn on areas that are patient-centered, you can advise the management, but you should not do a wrong thing, because the management will not be there to protect you when you get into the wrong hands of the law, or when you harm patients, or when you don't do quality work, or you don't provide quality services to your clients. So you can advise the management, but I also advise you not to indulge or to provide your services in a manner that that compromises the quality and safety of our patients. Thank you.
Thank you so much, Bruce. I think we have exhausted all the questions that were raised, and probably I will allow you to give us a summary and your parting shot, because we are nearing the end of this presentation. So welcome back, Bruce.
Thank you so much. So patient safety is something that is coming, something new that is coming in the line whenever we are providing our services to our clients. So it's something that we need to take very, very seriously. And whenever an incident occurs that is safety related, you should take that opportunity to improve. And even if it's reported or unreported or not documented or documented, it should not be used as a punishment to the staff involved, but it should be a lesson to learn from that incident and improve our services. And just as we also discussed in our introduction, there is a quality healthcare and patient safety bill that is within our in our parliament for debate. Very soon it will be signed into law, and it has got the legal frameworks on patients' rights, and also how us as the providers we can be protected, and also to the facility on the guidelines on safety issues to follow. So let us take time, go through that bill. It is very, very important for us so that we also don't get onto the wrong hands of the law, because it has got legal issues within it. Whenever you are on the wrong when providing services to the patient, it has got penalties for even for the facility that is not complying to the service provider that is also not complying. So let us take this area very seriously so that we can improve the quality of services we provide to our clients. Otherwise, I want to take this opportunity to thank the attendees for their time. I also want to take this opportunity to LMSK for providing me with this platform to share whatever I had on quality improvement and patient safety. Otherwise, I wish you all the best and happy Mashujaa. Over to you, Arthur.
Thank you, Bruce. Now, as we wind up, here are a few key reminders for our participants. Now, on number one, you can revisit this content and more CPD modules on our Learning Hub under www.lmsk.co.ke/CPD modules. Two, you can also join our growing professional community WhatsApp group via the links that we do share. And then three, if you haven't yet, we urge that you register in our next webinar into our groups, and also register and be part of the participants in our next webinar presentation. We also urge you to join our online platforms like the Facebook. The Facebook generally, that is where we have a lot. We also have a WhatsApp channel. We urge you to also join that as well. And finally, on behalf of Lab Medicine Society of Kenya, we thank you all as our participants, and we also thank our today's presenter, Mr. Bruce. And we urge that let's remain striving for excellence as we continue attending Lab Medicine Society of Kenya webinars so that we are able to improve on our laboratory quality and patient safety. Until next time, stay safe and committed to quality. Thank you and have a great evening ahead. Happy Mashujaa Day.